Hello, Dr. Sil here, junior doctor working in Sydney, Australia, and in this episode of Intern Diaries, I'm going to reflect a little bit about my time as an after-hours doctor. The after-hours doctors are the ones that work kind of overnight, and I've just finished 3 sets of nights, and I'm done with nights for a little while, and I'm very happy to see the end of it. After hours can be very intimidating and daunting, so I'm going to just give a little bit of insight into what it's actually like. So this video, we're going to cover number 1, why is after hours so daunting? Number 2, what does a normal shift actually look like? Number 3, I'll tell you about 3 very impactful things that I saw, like kind of life-changing things, some experiences that I saw. And then number 4, I'm going to talk about C-sections. I'll explain more later. If that sounds interesting, then let's get started. So first of all, why is after hours such a daunting term? Well, I guess during the day, which is when you usually spend your time at hospital when you're a medical student, and most of the time when you're a doctor, you have your team, your boss, and all the other doctors in the hospital who are very easy to contact and all around you. Plus there's a lot of staff, a lot of nurses, a lot of phlebotomists, the blood collectors. It's a well-staffed operation in the hospital during the day. At night, it becomes a skeleton crew. And at the hospital that I work at, which has, I don't know, maybe like 400 beds, there's only 3 kind of medical doctors at night. There's me, the intern, then there's a resident, and then a registrar. And if you're in the States, then a registrar is the same as a resident. Basically, there's just 3 of us covering the whole hospital. And that makes it very daunting because that means, you know, we're not just seeing patients from just the gastroenterology specialty team. We're seeing anyone and everyone who gets sick. So that could be cardiology, gastroenterology, surgery, aged care. It could be so many different things. And if they're sick, you have to get a good idea of who they are, and you have to do it quickly because there's other people who are sick usually. So you have to go through the notes and then see what the issue is, and then essentially try to fix that issue as best you can until the morning team gets there and they can do the more long-term changes. Anyway, it can be very daunting because it's hard to get a good understanding of who someone is quickly. And honestly, I feel like this is one of the skills I was least prepared for as a student. The skill of kind of looking at an electronic medical record and then understanding who a patient is, why they're in hospital, and what are the issues, and what are the issues that I have to address. Because as a medical student, I was observing as opposed to actually trying to get into the electronic medical record. So that would be a tip for you guys if you're medical students. Spend some time actually going through the medical notes and getting a mental picture of who the person is and what the issues are. Okay, now let's talk a little bit about what a normal shift is like. Now, I think it is true that no 2 shifts are the same because there's so much variability in who you can see. It is quite unpredictable, but there's kind of some predictability to it. So you start at 9:30 p.m. if you're doing nights, and you get a handover from the evening team who have been working from 4 p.m. to 10 p.m. They tell you what all the active issues are and who all the sick patients are. So they'll say overnight, this patient we've had to see him 3 times, he's been really unwell, he's needed 2 blood transfusions. You'll probably have to see him again in an hour if he gets unwell again. You'll probably have to give him another blood transfusion, and blah, 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 and you'll have to call this boss. So they'll kind of flag all the very sick patients in the hospital that we'll have to see. They'll also hand over tasks that haven't been completed yet. So for example, if they had seen a patient but they haven't ordered the scans, they might say, look, I just saw this patient, he needs a CT abdomen. I haven't ordered it yet, but I have to go home now because my shift is over. Can you please order the CT scan and review the results, and then call who needs to know? If there's abnormal results, call the appropriate kind of specialist in charge. So that's kind of the handover. They tell you who's sick and also jobs that are outstanding. Then after handover, you basically go to the census task list, which is essentially a to-do list. You don't get to put your jobs on the to-do list. Other people do. So this is the hospital to-do list, and essentially nurses can put on jobs that they need your help with. So if they need a medicine recharted because it was maybe incorrect dose or something, or they need some fluids because someone's going nil by mouth before an operation. They might need a fresh cannula because the previous cannula they've been giving intravenous drugs in has now tissued and isn't flushing well, or it hurts, or whatever. So there's all these little jobs that, I'll be honest, can get very annoying. Like, you can only put so many cannulas in before you get like sick of another cannula. But fortunately, nurses are getting really good at cannulas, so you can spread the workload of cannulas. So you do the census task list, and whilst you're working through the census task list, you will have a pager, and that pager will beep. Pagers take priority and usually are for like pretty high priority tasks, or they're for sick people. So you might get 3 types of calls. You might get a clinical review, which means you have to see a patient within half an hour. These are non-urgent. You don't have to stop eating. You don't have to stop, you don't have to quickly finish at the toilet or whatever. You have half an hour to see the patient. Don't run. Just go through the patient notes, see what the issues are, go see the patient, everything's fine. Then there's rapid responses. These are a bit more urgent. Rapid response is what it sounds like. As an intern, you go straight to the patient. The senior doctor will also have to attend a rapid response. They don't have to attend the clinical reviews, but they have to attend a rapid response, and they might be a bit behind you because they're seeing other rapid responses or something. So go straight to the patient, try and work out what's going on. Then there's the third call you might get, and unfortunately this can be sometimes common, depending on the night, and that's a code blue. And a code blue is you stop what you're doing and you go straight to the patient as quickly as you possibly can. So if you're weeing or whatever, you stop weeing, you go straight to the patient. On my last shift, I had 2 code blues in 10 minutes. We had to split the team up, 3 of us. It was very stressful, but it was all good. The patients had good outcomes in the end. But anyway, code blues are the most intense. So whilst you're going through that census task list, completing the jobs like cannulas and fluids and medicines, you also have to go and see patients for clinical reviews. Okay, so that's a little bit about what the shifts are like. Now I just want to tell you, I just chose 3 things that I saw that were unique to working in after hours. The first thing I want to talk about is recognizing a sick patient. As I was just saying, clinical reviews are non-urgent. You can go see the patient within half an hour. I had just gotten, my first thing I want to share with you is I had just gotten a clinical review for an old guy. He was like in his 80s, he had dementia, and he came in with a pneumonia. And the clinical review is because he was desaturating a little bit, which means the oxygen, he just wasn't breathing as effectively. The oxygen wasn't getting into his blood. It wasn't too bad, but it wasn't great. Because he had this pneumonia, they had to do a COVID swab and isolate him until it was negative. He had desaturated to 92% with 2 liters of nasal prongs, which is like pretty moderate. Like that's a pretty moderate pneumonia. It's not minor and it's not severe, but it's in the middle range. So he was on the right antibiotics, the moderate level antibiotics, and I went to go see him for that. But when I went into the room fully gowned, I looked at the monitor, and instead of 92%, it had gone down to 85%. He was going downhill. Boom, turn the oxygen way up. Boom, I'm calling for more help from nursing staff to get a Hudson mask. And then as I'm getting all this ready and thinking of escalating this to my seniors, bang, his oxygen goes down in front of my eyes to 80%. So he's desaturating while I'm putting more oxygen on. Code blue, call it. That's what I said to the nursing staff. Sorry doc, the do not resuscitate orders specify he's not for code blues. Okay, damn, call a rapid response and page it twice because I need my senior doctor here now for advice and input on what to do for this guy who is going downhill and quick. I'm worried about this patient. I'm staying by his side the whole time. Instead of going into all the nitty-gritty of oxygen deliveries, essentially there's a hierarchy of ways to deliver oxygen. He was on nasal prongs. I escalated to a Hudson mask. He kept getting worse, so I escalated again to a non-rebreather mask with maximum oxygen. Any intern, any medical student can do this, so it's good for you to know if that's the area you're in. So I'm giving him maximum oxygen and he's still desaturating. He went all the way down to 70 and then popped up to around 79. Really, really low levels. We want above, 95%, and he's at the 79%. Really low levels of oxygen. I'm getting worried, so I'm trying to think of what I can do for him. The next level up of oxygen delivery is high flow nasal prongs, which you cannot give to someone who is COVID pending because it spreads COVID everywhere. And then the next level up from that is intubation and ICU, which he was not for because he was so frail and elderly that he wouldn't survive an intubation. Gosh, it's a bit of a complicated situation. So what we did is we re-swabbed him we gave him maximum oxygen, re-swabbed the COVID test, and did it with a rapid swab so that it could be done in half an hour to an hour. So we had a really rapid response. The second we got that back, we increased it to high flow nasal prongs. We called the family in because we were worried that he wasn't going to survive the night. We gave him stronger antibiotics as well. We also did an ABG to look at the oxygen levels in his actual blood to see what they actually were, and absolutely they were really, really low. So this guy was really sick and we didn't think he was going to survive. We told the family, we told the boss, and all that. With the boss and the family's input, we all decided to put him on the palliative care pathway and the end of life care pathway, which is extremely sad. He was 87. When someone dies, it's very rough. Luckily, he had his wife with him when he passed. She was very distraught and it was heartbreaking. And I had to pronounce him death, which is something else you do as an after-hours doctor. You have to pronounce the death of patients. There's just so much experience, knowledge, and life that has been lived that expires and that disappears when someone dies. And so it's always really sad. The second thing I want to talk about is the importance of end-of-life care pathway, because after hours you have to deal with people who have terminal conditions but might not be on end-of-life care pathways. So what do I mean by this? I mean, we had a guy who had a terminal condition. It was idiopathic pulmonary fibrosis. So his lungs are essentially failing and there's no clear cause as to why, but he's becoming more and more breathless. There are ways to treat it and he was being treated, but there's no way to cure it, and it gets progressively worse until you die because your lungs aren't giving your blood enough oxygen. So pretty similar sounding story to the first, but this guy was young. He was 60. He was well, no other medical conditions. He looked youthful, but we went to see him and he had the same story, desaturating, oxygen's going through the floor, breathless, tripoding, blue, cyanotic, and he's got the high flow nasal prongs. He's got the maximum amount of oxygen we can give him, but he doesn't have the medicines charted that he needs to be palliated, to be put to sleep. And unfortunately, he died. It was a very sad death because the family wasn't ready for it. And I feel like, personally, when I see someone die from a specific condition, like idiopathic pulmonary fibrosis, I get this weird feeling like I'm meeting the disease, and I've started to have it with a couple of things now. Like I feel like I've now met idiopathic pulmonary fibrosis, and it's an evil thing, and it's a torturous thing. It keeps you short of breath. You never catch your breath. It's horrific, and I guess it's like anthropomorphizing it a bit, like making it human, but it just feels like that's the disease that's kind of infecting someone, and now I've seen what it can do. Like I'll never underestimate it again. I'll always take it. I always did, but like now I've got a personal connection to it. If I ever see a patient with it, I know not to mess around. I take it very seriously. Okay, I know that was only 2 things and I said I'd cover 3 interesting stories, but I don't have time in this video. It's getting too long. So the last thing I was going to talk to you about was C-sections. So far, very nice things about being an after-hours doctor is that you are also the assistant for emergency C-sections, which usually are a very stressful time for the mother. Can't imagine many things more stressful than an emergency C-section. Like you're giving birth to your baby. It's meant to be a nice thing. You find out that the baby's in distress and unwell, so you get carted away into the operating theaters to have a C-section. It can be extremely daunting. But from the intern's perspective, it's actually quite nice because first of all, you have a chaotic situation that you're helping reduce the chaos of. You're assisting in the procedure, so you just do what the surgeon tells you to do, which it often involves like retracting, holding things in certain places, helping with the suturing. You don't actually have to suture, you just hold the kind of, what do they call it? You follow them with the suture, so you kind of just hold the tension while they suture. You can suction, you can sponge, you can help clean. And the most important thing you do as an intern is you push. You are essentially that woman's uterus. And the uterus is very important in getting a baby out. So you have to push, because if you don't push right, things can be very bad. So I got a very sore right shoulder from all the pushing I had to do, because essentially you have the woman lying down and they're pregnant. They've made an incision on the uterus, and so the baby's head might have popped out. But then there's no strength in the kind of uterus because the kind of woman doesn't know to push because they have the spinal in, the anesthetic. So you have to grab the uterus and you push. And my gosh, you push so hard. You really push hard. It's pretty ridiculous. And not, it's not just about being hard. It's about being constant pressure and a certain kind of movement to it. And then you kind of deliver the baby. And that's kind of nice. It's a very nice way. I had a set of 7 nights, and on the last 4 nights, I did an emergency C-section every single time. All right, guys, I am done ranting. Thank you so much for joining me on Storytime. I hope you enjoyed it. I wish you all an absolutely lovely day. That is it for today's video. If you want to support me, consider joining me on Patreon, YouTube members, liking the video, sharing it with your friends, blah, 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 all that good stuff to help me personally. I really appreciate it because I love making these videos. And I will see you all in the next one. Bye for now.